Welcome to the informational webinar about the Pilot Awards competition to fund promising demonstration technology projects that improve the care and health outcomes for older Americans, including persons with Alzheimer's disease and related dementias. This competition is funded by the National Institute on Aging, or NIA, through its AI and Technology Collaboratories for Aging Research, or AITC program. We also refer to it as the A2 Collective. I am Rose Lee. I'm the principal investigator of the A2 Coordinating Center, and I will be moderating today's webinar. I want to introduce two key members of my team, Managing Director Rob Verheyen, who heads up operations, and Managing Director Stephen Liu, who heads up marketing, outreach, and business development. Our role as the Coordinating Center is to harmonize, coordinate, and communicate on behalf of the A2 Collective. You can always reach us at support at a2collective.ai, which is on the screen right now. We are delighted at the interest we've seen in the A2 Pilot Awards competition since we launched last week on January 10th. We have over 200 people registered for today's webinar. So that's really wonderful. Our plan today is to spend the first half hour introducing the key features of the program, and then break into one of three groups based on your expressed interest when you registered, with leaders from each of the three AITC collaboratories. We will not answer questions in the first half hour, but you are welcome to input questions using the chat function, which I see some people are already using. We will make every effort to answer all the questions and post them on as FAQs on the A2 Collective website by the end of this week, along with the recordings of the presentations. The A2 Collective is comprised of three collaboratories: the Johns Hopkins AITC, Massachusetts AITC, and Penn AITC, and the Coordinating Center. So the collective is all of those components. Applications for pilot projects will be accepted through February 18th, with awards anticipated by May 31st. One of the unique features of this pilot competition is the emphasis on partnerships. Each of the AITCs and the Coordinating Center are committed to working collaboratively with researchers across private industry, venture capital firms, the healthcare sector, government agencies, and the NIA Office of Small Business Research to provide technical support for scaling up pilot studies. We encourage you to become familiar with the features and resources available from each of the AITCs to help you craft a competitive pilot award application. Part of the evaluation criteria will depend on the pilot project's alignment with the collaboratory you choose to partner with. Each collaboratory has in-house scientific and technical expertise and the clinical and industry partnerships necessary to help facilitate the identification, application, and integration of AI approaches and enabling technologies into devices that address the aging research priorities. This could include, for example, access to established patient populations, or experience with programming wearables, or help with prototype creation. These are just some of the types of resources that the AITCs can bring to your pilot idea. There is $40 million set aside over the next 5 years to fund pilot projects. We view this as an opportunity for you to build a relationship with the A2 Collective, since there will be subsequent competitions to learn from this experience. So if you apply and you're not successful the first round, you may find it beneficial to work with the AITCs to strengthen your application. Each of the three AITCs has prepared a brief introduction to their collaboratory offerings to hopefully entice you to visit their breakout. After the brief introductions, Rob will provide instruction on how to navigate between the breakouts should one end early or you want to visit one of the other AITCs. Also wanted to mention that Steve put in the chat, awardees are also eligible for 10,000 in AWS credits and support.
I'm Jeremy Walston, one of the co-PIs of the Johns Hopkins Artificial Intelligence and Technology Collaboratory for Aging Research. Welcome to our webinar today. We're here to tell you briefly about our AITC and the amazing resources that we can offer up to the research community. First, I'll show you a slide that covers our philosophy and really what we're trying to accomplish in our AITC. On the left, you see a figure of older adults and several of the domains that we know are important in clinical care in older adults, aging and medical related conditions, social and behavioral domains, and cognitive domains. And you see a number of medical and social issues that accompany aging. And in geriatric medicine and in healthcare in general, we've been working hard to try to solve some of these issues. On the right-hand side, you see artificial intelligence and the potential programs that we have at Johns Hopkins that could be utilized in helping to solve problems of older adults. And here you just see several of the terms: natural language processing, expert systems, vision systems, speech, et cetera. And several of the ways that these engineered approaches can be utilized to help solve older adults. Traditionally, there have been many barriers to connecting these worlds just because of unrealistic expectations and no real connections between clinicians and engineers. But through our AITC, we're hoping to be able to connect these worlds and rapidly expand the technologies that can be used to help older adults. We have a great transdisciplinary ecosystem developed here. In the center, you see the big orange circle, our Hopkins AITC. And around the circle, you see domains of first clinical resources that we bring to the table. You see a number of programs here that we'll talk about more in the breakout session that can be accessed and help facilitate the development of pilot programs. On the left, you see green circles, many of the amazing research programs in engineering that have been focused on some health-related issues, not specifically related to aging, but certainly able to turn their attention towards some of the important issues that face older adults. And finally, at the bottom, the orange circles, we have a vast infrastructure of a business school and a Johns Hopkins Technology Ventures that can help with business development, IP development, and taking successful technologies and uses of AI out into the business world and business development world. So for more rapid integration into the healthcare world. So for our pilot programs, we have two offerings. One of them is around Alzheimer's disease and related dementias. And in the circle in the center, you see the domains that we are interested in working towards: patient care and engagement, diagnostics and assessment, system management and administration, and caregiver workforce. Caregivers and workforce. And so again, we're trying to solve problems in all of these domains using engineered approaches that you see in the center here: robotics, machine learning, big data analytics, et cetera. And around this circle are potential examples of problems that we could be targeting in our AITC, and that pilot projects, we hope that pilot projects will work to address. We'll talk more about this in the breakout session later, and we'll be open for questions about each of these domains and areas. A second pilot program that we have is related to the maintenance of independence in older adults. It's different than the cognition and AD focused first pilot. These are often issues more related to functional decline or social engagement, other issues that aren't exactly in the cognitive domain. But again, you see the same issues or domains of interest for our program: diagnostics and assessment, system management and administration, caregiver and workforce, and patient care and engagement. And again, we will address these in more specificity during the breakout session of the webinar in a couple minutes. Finally, I wanted to highlight the world-class research resources that we at Hopkins can bring to the table through various partnerships. And again, we'll discuss this in the webinar. We have a registry of hundreds of older adults through our Older Americans Independence Center. These adults are willing to participate in studies and engineering studies certainly could be part of that. We have numerous clinical care programs for older adults, and especially for AD and AD-related conditions. We have a broad network of access to older adults in urban and rural communities, as well as access to stakeholders to get opinions from them about various technologies. We have electronic medical record support for multiple conditions that impact older adults. In the engineering world, we have this vast collaborative or partnership opportunities in programs for robotics, computer vision, machine learning, speech and language processing, and AI applied to healthcare and imaging sciences. So those are just a few examples. We also have an amazing precision medicine analytics platform that's been developed over the years here at Hopkins that is accessible through collaboration and partnership. And finally, I mentioned the business development and VC networking opportunities that we have here at Johns Hopkins that can help take ideas more quickly into the business community and into integration into society through products. So with that, I will close. I thank you for your attention and look forward to providing many more details of our program in the breakout session that follows. Thank you.
Good afternoon, everyone. My name is Deepak Ganesan. I'm a professor of computer science at UMass Amherst. And I'm one of the co-directors of the Massachusetts AI and Technology Center for Connected Care in Aging and Alzheimer's Disease. The other co-director is Nitish Chowdhury, who's a professor of medicine at Harvard Medical School and a physician at Brigham and Women's Hospital. Mass AITC is a consortium of 5 sites: UMass Amherst, Brigham and Women's Hospital, Mass General Hospital, Brandeis University, and Northeastern University. And across these sites, we bring together pre-existing research centers that are highly complementary and are very relevant to the overarching theme of the Mass AITC. At UMass Amherst, we have the Institute of Applied Life Sciences, which has a large number of core facilities to develop AI-enhanced technologies, to validate them, to construct the analytic solutions for them. At Brigham and Women's Hospital and at Brandeis, we have 2 Roybal centers in the area of aging. Brigham has the Roybal Center for Therapeutic Optimization using behavioral science, and Brandeis has the Roybal Center for Active Lifestyle Interventions. At Mass General Hospital, we have the Alzheimer's Research Center, which has a standing cohort that they've been following for many years and decades. At Northeastern, we have a technology-focused Center for Technology in support of self-management and health. So by bringing together all of these existing research centers under a single umbrella, our hope is to really support and accelerate the research being done in the pilot projects under the Mass AITC. And we provide a combination of unique state-of-the-art research facilities for developing and validating technologies, as well as access to patient cohorts, both in urban areas and in rural areas. Our focus is on technologies that would work in a remote setting, meaning at home. So we are looking at wearable technologies, contactless sensing technologies, mobile phone-based solutions, things that would really work in a remote context to enhance, our support, to effectively support healthy aging and the care of patients with AD and ADRD at home. We're looking at analysis or analytics on these kinds of longitudinal data collected from these kinds of sensor devices, or smart home types of sensors at home, combining all of these analytics to provide solutions that will work both from a self-care perspective for patients, from a clinician-focused perspective, as well as for caregivers, and to connect these individuals, although they might be operating in a remote context. We, as I said before, we have a lot of facilities and strengths and resources to offer across our center. So, all the way from development of technologies to benchtop validation of technologies in the lab studies, whether it's in a gait lab or sleep lab, smart home-based naturalistic studies. So we have smart homes at several sites, which are highly instrumented if you want to have realistic yet highly instrumented settings within which to obtain data sets or to validate your technology solutions. We have several cohorts and the ability to scale these studies using software infrastructure that we have developed in order to be able to roll these studies in a remote context. and many other types of resources. So, and we have an excellent team with expertise in all of the diverse areas that are relevant to, AI-enhanced technologies for remote monitoring at home, as well as the aging and the AD side. So we have expertise in wearable sensing and wearable devices, mobile technologies, analytic solutions and machine learning, specifically for analyzing longitudinal sensor data from these kinds of devices, usability issues, aging, Alzheimer's care, sleep, and so on. So if you're interested in this area and in our center, we encourage you to reach out to us. Please do send us a short description of what you're thinking about, and we'd be happy to connect with you, fill any gaps in expertise or resources that you might need, and help you enhance and improve your pilot proposal. The email address is pilot-info@massaitc.org. I look forward to hearing from you. Thank you.
Welcome to the Artificial Intelligence and Technology Collaboratory for Healthy Aging at the University of Pennsylvania, an initiative funded by the National Institute on Aging. My name is George Demiris. I'm a faculty member in the School of Nursing and Perelman School of Medicine at the University of Pennsylvania and one of the principal investigators of our collaboratory. The overarching goal of the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging is to identify, develop, evaluate, commercialize, and disseminate innovative technology and artificial intelligence methods and software to support older adults and those with Alzheimer's disease and related dementias in their home environment. The collaboratory is motivated by the need for a comprehensive pipeline from technology-based monitoring of older adults in the home, collection and processing monitoring data, integration of those data with clinical data from electronic health records, analysis with cutting-edge AI methods and software, and deployment of validated AI models at point of care for decision support. A central focus of the Penn AI Tech Collaboratory is to advance this vision through the solicitation, review, and funding of pilot grants focused on technology and AI development to advance the science of care management and aging in place for vulnerable older adults or those with Alzheimer's disease receiving skilled home and community-based services. Funded pilot projects will be supported through cores focused on administration, stakeholder engagement, technology identification and training, clinical translation, validation, networking, and ethical and policy issues. Our pilot grants will be actively partnering with Penn AI Tech, and that means they'll be able to access many of our resources, including an extended network of clinical sites, that includes large home health and community health sites and health systems, our existing and available artificial intelligence software and infrastructure, and our expertise in geriatrics, informatics, and artificial intelligence. Funded pilot projects will receive ongoing feedback, mentoring, and guidance from our 8 cores. We welcome academic, industry, and clinical sites to apply. For more information, please visit our website. Thank you.
Okay, thanks very much to the 3 AITC PIs. We'd like to now introduce the 2 NIA scientific research leads for the AITC program. Dr. Partha Bhattacharya is with us, as is Dr. Marcel Saliv. Partha, would you like to say a few words about the motivation behind the program and intended outcomes?
Thanks, Rose, for the introduction. First of all, I'd like to thank all of you for joining us today. The initiative we have today is supposed to improve lives of older adults with technology and applications of artificial intelligence. And how do we do that? Most of the applications that are available today are available for younger generation, and technology that is being applied are readily made available for younger generation. But older adults are often overlooked. This is a population that can potentially benefit from advents of technology. And our hope is all of you will take this opportunity to this program. This is a national competition. You'll take an opportunity to apply and benefit the older adults. Older adults will benefit from your contribution. Rose?
Oh, thank you very much, Parsa. Marcel, would you like to say a few words of greeting or?
I think Partha said it well. I'm just happy to be here and collaborating along.
Thank you very much. All right, I'm going to turn it over now to Rob Verheyen before we break into our breakout sessions with a few instructions.
Thank you, Rose, and thank you, Partha and Marcel, for your comments as well. We're actually running slightly ahead of schedule, which is great. We'll have plenty of time this afternoon for really the meat of this webinar, which are the breakout presentations with the 3 AITCs and their presenters. I want to thank you all for joining us today. We're excited to see such a large turnout for the inaugural A2 Pilot Awards competition. As Rose said, my name is Rob Verheyen, and I'm the A2 Coordinating Center's Managing Director for Operations. I have just a few housekeeping items before everyone moves into their breakout room assignments. And some of these will address some of the questions we've already seen come into this main chat. First, this welcome webinar and the AITC presentations, which will begin each of the 3 breakouts, will be recorded and they will be made available for on-demand viewing. Our aim is to have those videos available on the A2 Pilot Awards website by the end of this week. We will also be recording the Q&A during each breakout session, but plan to only use that recording to gather questions from across the 3 breakout rooms and then post questions and answers in the FAQ section of the Pilot Awards website. If you haven't already visited our website, we do have a variety of FAQs already posted there, and we'll be using the Q&A from these 3 breakouts today to augment what we already have there. Secondly, if you haven't already done so, we strongly encourage you to visit the A2pilotawards.ai website. That's in the upper right corner of the slide here, and click the apply button. That will take you to the applicant registration account, which we encourage you to create an account as soon as possible. Doing so will give you immediate access to the platform and all of its interface tools, as well as the live pilot application, so you can get a sense of how the final submission will be put together. We do recommend that you take this step now to ensure that you don't experience any technical issues before the deadline date of February 18th, and that you can interact with the portal to get a sense of how it'll work. Lastly, as we've noted here, in a moment, you'll be moved to the breakout room based on your first selected AITC when you registered for this webinar. If by chance you find yourself in the incorrect breakout room, or if the breakout that you're in ends early and you want to visit another breakout, you can select the breakout room's selection on the Zoom toolbar and then click Choose Breakout Room and select Join for the desired room. Alternately, you can exit the breakout room that you're in at any time. That will return you to this main room where our technical manager will be able to get you to the place that you'd like to be. Lastly, for the questions and answers portion of the breakout room, we ask that you chat your questions and that you use the raised hand feature to draw the presenter's attention to your question. I believe that takes care of all of my housekeeping logistics things. Again, we thank you all for being here. And at this point, we'll begin moving you into the assigned breakout rooms. When those breakouts end, by the way, you will not come back here. And so as breakouts conclude, you can either move to another breakout if it's still ongoing or exit the meeting. Thank you all again.
We're going to run this sort of as a group effort. I'm going to start off and then have other investigators in our AITC chime in about the resources available, and also be available for the question and answer session towards the end. So we're going to provide a little bit deeper dive into our program, and then again have it sort of more open for questions at the end about applications and sort of the direction that we think our center can best support your projects. Again, there are other centers as well, and so I think all of those breakout sessions will be available later if you want to look at those as well. Okay, so in the beginning session, I provided the overview of our center, and this is a really great slide that Peter Abadir and others developed when we were writing our application. And again, this is the kind of heart and soul of what we're trying to do. On the left, you see older adults and a number of clinical and social issues that we think or that we know as clinicians impact their health and well-being. And on the right, you see artificial intelligence and all of the engineering approaches, uses of AI approaches that might be relevant to improve the health and well-being of older adults on the left. Traditionally, we have not been together very often, engineers and medical providers, but I think this is going to be a great collaboration and a great way to get us all into the same room, keep us all into the same room, and help solve some of these problems. And as Partha mentioned, we really want to push some of these ideas out quickly and get them into the next phase of development and out into the commercial space where we know that they can be much more rapidly adapted and make an impact in older adults. Next slide. So this is a kind of a flow of our center and the various cores. So we have a stakeholder engagement core and a tech ID and training core. We didn't get into the weeds of these very much, but these are also very important, I think, to the life of our center. We want to make sure that stakeholders are engaged from the very beginning. And these stakeholders are older adults, especially in rural and urban settings that are often underserved. So we want to make sure they're encouraged to participate in this and to get ideas about new technologies, but also get a sort of a sense of utility to them and if they would actually use some of these products that might be coming along. So that's embedded in our center, along with a tech ID and training core. Even in addition to these pilot programs that we're developing, we want to look at new technologies that are evolving and technologies that are already being used for other issues or other medical issues and healthcare issues, and see if they can be adapted and moved towards older adults. We also want to be able to train people that are interested in this space, more junior investigators or people who are just starting companies, and try to get them to work with us to kind of foster new technologies, new ideas, and get them trained up in order to apply for these pilot resources. I'll skip across the way there to the clinical translation and validation core. That's that little green box to the right there. And that core is really meant to help test feasibility in new devices. So in addition to these pilot resources for development and testing, we also have this core which will work with investigators to think through new ideas, maybe test new devices, help with the development of new devices. And certainly not large scale, industrial scale testing, but certainly sort of smaller scale, very beginning ideas. And we'll hear more about this later from other investigators. We have an administrative core that kind of thinks about the big picture of this. And on this slide, there isn't the data core, but we certainly have a very large and vigorous data core that will be incredibly helpful in assuring that any data that's coming out of any new technologies is measurable, studyable, quantifiable, and useful, mostly, hopefully in the long term as we move towards product development. We will review our pilot proposals through this administrative core and a panel of experts from our center, from the other centers, and from experts around the country. And these highly scored conceptual proposals will be invited to submit a full application. We've sort of in that early phase of that now, and these RFPs will be important in that. And again, we have two pilots. Pilot A, which is the Alzheimer's disease pilot, there's actually more funding in the AD related pilot core. So if you have an idea that's related to AD or dementias, I think most of the programs have more money in that side of things, but also there's a substantial amount of funding in the pilot core B. for more aging-related issues that are not specifically related to cognitive decline. And we'll talk more about the, the types of programs that we're interested or that we think we can support moving forward. Next slide. This is our collaboratory, the people in our collaboratory. And again, I think one of our strengths is that we have this great diverse group of individuals really committed to this program. You see their faces there. We are the co-leadership with me is Drs. Abadir, Drs. Hager, and Drs. Chalapa. And again, we're clinicians, researchers, engineers, and we really have melded well together to kind of put this program together. You see many of the other program leaders listed below. So people from the stakeholder core, Tech ID core, the AD and ADRC related pilot core, and Dr. Saria from the geriatrics pilot core. Dr. Fan is from the school of the business school and has been really instrumental in helping us think through ways to connect with businesses and network ideas and potential business ideas out really across the country for both startup purposes and for engaging larger existing businesses in this aging space. And then Dr. Shute there you see is responsible for the development of PMAP at Johns Hopkins, which is we'll hear more about in a little bit, but this really important space of data integration and data quality, I think is going to be instrumental in making sure that anything we support is going to be rigorous enough to kind of move forward into the real world settings. You saw this slide before. This is our sort of a demonstration of the deep roots we have at Johns Hopkins, and across the right here, you see the clinical programs in the yellow circles, rural health in collaboration with a group in Iowa, also an extensive VA network there. Our Older Americans Independence Center is focused on both frailty and resiliency. Division of Geriatric Medicine here is a real powerhouse in the country and have really diverse clinical programs that go from nursing home care to inpatient care to ICU consulting care, and every sort of research program in between. We have a very vigorous Alzheimer's disease, both clinical and research program at Hopkins, and a Center for Health Equity that focuses on urban adults and especially older adults. On the left, you see the green arrows here, and Peter Abadir will talk in more detail about these programs. The left, the green circles are some of the engineering programs that I think will be relevant for this, and Dr. Chalapa will talk about that. And then at the bottom, business schools, schools of business, and our Johns Hopkins Technology Ventures program, which helps investigators, at least at Hopkins, start up businesses and connect them to both VC and other funding opportunities to get small businesses going around ideas that might evolve from technology and uses of AI. With that, I will turn it over to Dr. Abadir, who will talk about some of the clinical opportunities that your program may benefit from.
Thank you, Dr. Walston. Hello, everyone. My name is Peter Abadir. I am an associate professor of geriatrics medicine at Johns Hopkins University, the Division of Geriatrics Medicine and Gerontology. I'm one of the co-PIs on the AITC, the Johns Hopkins AITC, and I also direct the molecular measurement course of 2 NIA centers, including the Older American Independence Center, which is a large center program that focuses on the syndrome of frailty in older adults, and that's the functional decline that we see in a subset of the most vulnerable older adults, as well as a new resiliency center focusing on what makes certain group of people resistant to adverse outcomes. And you can see the implication of that in the relevance of those 2 centers in our AITC. I want to introduce you to the Johns Hopkins Bayview campus. Johns Hopkins was one of the first universities to pay attention to the aging tsunami. The idea that aging is a different entity in itself, and it's not that you give treatments to older adults similar to young adults. That there is a difference in treating and managing older adults with chronic multimorbid conditions. So Hopkins moved all geriatrics related specialties to the Johns Hopkins Bayview campus and brought all the subspecialists that take care of older diseases of older age, including osteoporosis, dementia, incontinence, et cetera, to that campus. Next slide, please. And just to show you the breadth of specialties that happens on this campus, you can see that this is the spectrum from outpatient clinics for older adults all the way to inpatient hospitalization. And you can see Elder House School is one of the prominent features of our geriatrics division. This is a group of older adults that are homebound, that physicians from our division will go and see them. The Hopkins Specialty Hospital is a full inpatient rehab unit dedicated to older adults after hip fractures, after surgeries, to get rehab therapy as an inpatient. The Hopkins Bayview Hospital, where I'm currently attending today, is a hospital that admits all patients, but majority of them are older adults, and currently, as many of other hospitals around the nation, hit heavily by COVID. Human Aging Project is an institute that's dedicated to study everything related to aging. And of course, you can see our AITC Biology of Healthy Aging program looking at molecular changes that happens with aging. And you can see the relevance of that if you are developing a device that you want to show that it helps with certain biomarkers of aging, including the chronic inflammation or mitochondrial changes. This is something that we definitely are known for. The Older American Dependence Center, I told you that this is a center focused on frailty. The Division of Geriatrics Medicine and Gerontology is, I think, the largest geriatrics division, probably worldwide, but most surely here in the US. The Education Center is a geriatrics education center that's focused on teaching caregivers, patients, providers on education. And the relevance of that is that some of the devices requires an element of education. So there's a world-class education center for transformative geriatrics with focus on hospital at home, connecting with patients at their own homes using telemedicine and health technologies. The PACE is Program for All-Inclusive for the Elderly. This is also a very unique program. Only I think 20 or 30 programs exist around the nation that older adults will come and spend the whole day, and they get full assessments, full medications, full treatments, everything, and leave and go home at the end of the day. A memory and Alzheimer's treatment center. Next slide, please. And a vast network of connections through our collaborators in rural Iowas, including the Veterans Administration and rural Midwest, with potential for connecting with through telehealth or through their network of physicians and providers in those rural areas. And this is an emphasis of the grant, that they want to see this go, the devices to be tested in real world. And definitely we can give a lot of support and give resources to help make that a reality. And network through our Bloomberg School of Public Health, which is the #1 School of Public Health in the nation. Next slide, please. Next, I would love to invite Dr. Feld Fenn, who is the core director for the mentoring and networking of our AITC, and he is a professor of business and as well a professor of medicine in the School of Medicine.
Thank you, Dr. Abidai. So welcome everyone to the Hopkins AITC. So my primary role in the AITC is to help facilitate connections between awardees and researchers to the larger business and venture capital community. So here at Johns Hopkins, we have built a fairly extensive national network of both large venture capitalist firms, which we will soon put up on our website, as well as large and small startup firms. So we have companies like Siemens, for example, Microsoft that are involved and have committed to supporting teams that are trying to commercialize their technologies. More importantly, the Carey Business School has been involved in innovation, commercialization for the better part of more than 10 years. In fact, the entire program at Carey is built around the commercialization of biomedical technologies. And so one of the things that we can provide, especially for teams that may not have very deep business resources, is help with market analysis, opportunity identification, as well as financial modeling. So on the one hand, while you're developing technologies in order to work with older adults in the AI space, it's sort of quite important to also start thinking about how you're going to commercialize these technologies, because the path of commercialization is going to have a big influence on the design of the technology itself, right? So what we do here is we try to help you integrate the design of the technology and its features together with considerations for things like how you're going to get it funded for commercialization, reimbursement and payment, insurance pathways, as well as we have help and connections to the regulatory agencies as well. I think the point being that what we're trying to do is to help accelerate technology so they don't simply remain on the bench. And what we have found, having done hundreds of these things with both internal Hopkins investigators, as well as the US Army, as well as the NIH and NASA, and various other private and public agencies, that I think we have a fairly good model, a fairly robust model to help you along. So you don't find yourself developing something that you're going to then face a challenge in trying to get to the marketplace. Because ultimately the goal is to get this into the hands of providers, to patients, to families, to caregivers. Thank you, Dr. Abidya.
Thank you, Dr. Fan. Next, I would like to invite Dr. Shalapa to present the engineering side of our AITC.
Thank you, Dr. Abadi. Hi, I'm Raman Shalapa. I'm a Bloomberg Distinguished Professor in the Electrical and Computer Engineering Department in the Whiting School of Engineering and Biomedical Engineering Department in School of Medicine. And I'm really excited to be working with physicians, Doctors Jeremy Walston and Peter Abadi, and many other co-directors. This effort brings engineers and doctors in the same space. So we have a lot of facilities, laboratories in the engineering space. Most of them are located in the Homewood campus, and I have listed some of them. And so the Laboratory for Computational Sensing and Robotics, which came about from a 10-year research supported by National Science Foundation on robot-assisted surgery between 1996 and 2006, and is led by Professor Russ Taylor. There are many labs in this laboratory. So many of them are dealing with robotics and interaction with humans, interacting with other agents, and so on. And we also have a world-renowned Center for Language and Speech Processing, which is the CLSP, Center for Language and Speech Processing. So mostly researchers there worry about processing speech and natural language for many applications, including gait analysis for monitoring of dementia and any issues with speech pathology for monitoring Parkinson's and other related diseases. We have Dr. Najim Deha here, who is an expert in speech and language processing. And the other lab I have put here is the one that I direct, which is AI for Engineering and Medicine. I came to Hopkins in 2020, and so I've set it up. And my expertise is in AI, machine learning, and computer vision. So we provide a lot of expertise in building robust machine learning algorithms for processing images and videos with applications in gait analysis, facial expression analysis, transfer learning, and fair and robust AI. All of these are issues when you're dealing with the data collected by various devices, wearable devices, mounted devices, and so on. Transfer learning is very important to see whether models developed for one population, how do you transfer to another population? And there is a lot of concern these days with AI, about whether we are collecting data in a fair way and whether it is robust to adversarial attacks and so forth. So these are some of the things we look at in this lab. There's also the Malone Center, which was mentioned before. Malone Center is where actually this P30 is residing. It's been there for almost 6 years now. It's the goal is to engineering for healthcare. So there are a lot of many constituent labs in Malone Center that's also available. We are actually trying to set up a subset of these labs in Bayview itself. So there will be much tighter integration between the clinicians and the engineers. And so more of that will be announced later. Thank you. Next slide, please. Next slide is, this is something that Dr. Walston mentioned. It's called PMAP, Precision Medicine Analytic Platform. Hopkins invented several tens of $millions to put it up. One of the issues in dealing with data is that data is very heterogeneous in medicine. You have the electronic health records, you have diagnostic images, you have conversations between the doctor and the patient and so forth. So how do you make them all live in the same space so that machine learning and AI algorithms can be applied to these different kinds of data? And this is a very unique facility at Hopkins. And Dr. Chris Chute is kind of very aware of what's going on with this. And so if there is a pilot project that has different kinds of data and you worry about what kind of machine learning algorithms should be applied, so that is something that we'll be able to help. So this is a unique facility at Hopkins. Next slide, please. So I'm going to hand it over back to Dr. Walston.
Okay, thanks. The next couple slides you've seen before. We put these up again just to kind of remind the group that we are interested in all of these kind of domains of care. So, you think about Alzheimer's disease, for example, or dementias that are related to that. There's certainly ways to diagnose it and assess it. And we think that, new technologies could be utilized to make that happen earlier. So that's kind of listed over here on the right-hand side and some of the areas that we think are kind of ripe for further development. In the healthcare world, there's sort of system management and administration of health programs, and often through workflows or improvement in so yeah, I guess workflows is probably the best way to put it. You can really make movements towards better efficiencies and also improved patient care. Presently in the caregiving and workforce areas, this is a massive need in the country right now. There's a massive shortage of nursing care and especially nursing assistants out there in the world, caring for older adults, both in the home care space and in facility space. So we really are looking for ways to improve the efficiency there, the kind of distribution of care, the efficiency of the workforce, training, anything in those spaces, I think could be useful things that we would welcome applications for. And then up there in the actual patient care and engagement, you see a number of things about treatments or symptoms management, psychiatric behavioral management, activity engagement, things that will help older adults with cognitive impairment maintain, maybe slow the decline in cognition, potentially improve it or stabilize it. There are many different approaches to do that. And so we're interested in engineered approaches to help with that, or uses of AI that might help with that. In the center, again, we put all of these potential ways that these could be approached in sort of the engineering and AI world. Certainly, there are many others, and we would welcome applications from all sorts of groups that might pick up on some of these and other technologies to move forward. The next slide looks very similar to the one that I showed before, the same domains, but some different projects here. So diagnostics and assessment again, and older adults. What's missing here is the cognition. We're looking more towards physical frailty or resiliency, diagnostic approaches using perhaps nanobiotechnologies that might help identify people at high risk earlier. Polypharmacy detection and treatment, for example, might be in that domain. I'll jump over here to patient care and engagement. Similar personalized diagnostics and treatment for things like muscle loss or sarcopenia and prevention of those conditions, which are really impact people's ability to maintain independence as they age. Nutritional optimization, there are lots of nutrition apps out there, not so many focused on older adults. And, you know, again, looking for innovation in this space, something that's really easy for older people to use or for the caregivers to use that would help facilitate optimization there. So again, some examples there. System management administration. So, you know, again, thinking about nursing homes and our hospitals or outpatient centers or booking appointments, all sorts of things you can think about that are just not often not optimized for older adults. And oftentimes it's very difficult for them to access health systems and to sort of tie into those systems. So we're looking for ways to improve that for older adults, to make it more efficient, make it more easy for them to access systems and health systems for sure. And then finally, again, I think in the last, even since we wrote this grant, this area has become so much more important. And there's, again, a massive shortage. And thinking about ways to use technologies to improve this caregiving and workforce training and sort of supervision of older adults that might be able to stay home but don't quite can't quite do it independently. Anything in those spaces would be welcome.
So Nitish Chaudhary, who's the co-director of the center, as well as Benjamin Marland, who's the associate director, are both on the call as well. So as I said, we are the Mass AITC. You know, we have 5 sites and faculty members and researchers across, physicians across 5 sites represented in the center. And we're really, you know, looking for interesting projects that take advantage of these resources to do interesting things. So I'll skip over some of the material that I already described in the short, brief overview. But just to re-emphasize some of the things that probably are useful to know, we are focused on technologies that work at home. So we are really looking at things that would work in a remote context, right? So wearable technologies, mobile based technologies, smart home technologies, contactless sensing technologies. These are the sorts of things that we're looking for. And of course, you know, if you have multiple different types of sensor devices that are monitoring at home, then you have to combine the data and analyze them. So we're looking for analysis and analytical solutions as well towards supporting patient care for clinicians, patient self-management, or for caregiver support. So in our RFA that we released on our website, that's also available as one of the downloads from the A2 site. These are the 3 topics that we listed very broadly as areas that we are looking at for this cycle. So the first bucket is largely on the device side. So we are looking at AI enhanced technologies, which is largely sort of hardware sensing devices themselves, as well as the analytics, but with an emphasis on lowering the burden. You know, older adults don't want to carry around bulky devices. So lowering the burden, reducing algorithmic bias. You know, one of the questions, one of the points that Partha made is that many wearable devices and other kinds of, you know, these technologies work for younger individuals or healthy individuals, or a different population from older individuals that we're targeting. So we are looking at solutions to that problem, improving the accuracy for these individuals, particularly those with impairments, whether it is physical impairments or cognitive impairments or sleep disorders. We're looking at accuracies, higher accuracies for this kind of population, improving access to these kinds of technologies, as well as usability for older adults, which is an important problem. So that would be the first large bucket around the device and the technologies themselves. The second one will be around, focused on the analytic solutions. So as I mentioned, you can have a lot of different sources of data, and these days, the number of sources of data just keeps expanding, especially what we can collect at home. But we need to analyze them. We need to combine that with other kinds of information like cognitive performance data, and then make it interpretable and actionable for a clinician or the patient themselves or caregivers, right? So there's that, it's not enough to have a lot of data. You have to make it actionable and interpretable. So we're looking for solutions around that. Finally, we are also looking for visualizations and data-driven visualization strategies, because again, there's a lot of, we are inundated with data, but we need to present it within in a way that people can understand and act on. So data-driven visualizations is another bucket. So these are the three broad areas that we're looking for under, under the overarching umbrella of our center. And one question I think we should, that the PO meant, the collective mentioned is the resources that each of the AITCs bring to bear. And so I wanted to touch upon the different ways you can engage with the mass AITC. So there's two broad ways in which I think we can help you enhance your pilot projects. One is resources, so we can connect you to the resources that would enable you to accelerate pilots and studies. This is a very interdisciplinary endeavor. And oftentimes we found that people don't have all of the expertise that would be required to go after an area like this, but you might have a technology expertise, we might pair you up with a clinical expertise and vice versa. So we can offer resources of various sorts, expertise as well as core facilities. And then the second one is facilitating collaborations. Again, as I mentioned, connecting the engineers to the clinicians or to the caregivers and vice versa. So let me touch upon each of these a little bit more. So in terms of facilities, I've just listed some of the facilities here. We can get into details. Some of the details are on our website as well. But we have a range of facilities, going all the way from sort of benchtop validation and of sensor devices, maybe even development of the sensors if that's of need, the analytic part components of that, various types of core facilities that are pay for use for validating the devices, sleep monitoring, exercises, gait monitoring, and so on. We have a number of smart living science types of facilities, which are quite interesting. So these are essentially full homes, home-like facilities, both in Northeastern and at UMass, that are equipped and fitted with sensors of various sorts. So they would give you the smart home type of environment in which to study the device, but in a more controlled setting. And then, of course, if you really wanted, if you wanted to go to the home and deploy at home, we have various types of both software as well as other kinds of resources and cohorts that you might be able to leverage through our center. Given our experience with deploying, remote studies, we have a lot of software infrastructure as well. I'm not going to dwell on all of the different things we have, but just to give you a framework of what's available. So we have there's obviously a range of different wearable sensors and other kinds of sensors. So you have to acquire the data from these sensors and mobile, often through a wireless connection through a mobile device. So we have infrastructure to collect various types of data streams, to store them in the back end, to visualize these data different ways, to push EMA's ecological momentary assessments back to the user to get real-time input. We have ways in which we can analyze and then push these kinds of EMAs in real time. So there's a range of software kinds of resources that if you were looking, if you had some part of the a project but not the software resources, we have a number of these that we can share with pilot projects as well. So I mentioned the team, but I think I'll sort of highlight that again. We have expertise in different areas, and I mentioned this only because if you come in and you would like you would like a collaborator in a certain area, we have ways in which we can connect you with the right person. And in some cases, some of the members of our team would themselves be the right person to talk to. So we have expertise in the wearable and contactless sensing devices, in the analytic methods, particularly machine learning for longitudinal sensor data that comes from these kinds of wearable and other sensor devices. We have usability experts, human factors expertise, aging expertise, AD expertise, and so on. So we have a range of different types of expertise that you can leverage as well. And yeah, this is probably the main, what you're here for, right? So we intend to support about 10 to 12 pilot, maybe a few more, maybe a few less, depending on the number of applications in the first cycle. Our pilots, the maximum is 200K, but the range, our median range, will probably be roughly in the ballpark of 100 to 150K in direct cost for 1 year. So in terms of the review criteria, we've listed a few on our RFA on our website as well. But the primary ones obviously are scientific merit. How innovative is the idea? We're looking at emerging, interesting technologies that have potential for significant impact. And so, the innovativeness in the ideas and the ability to have an impact is important. The investigator team, or at least the interdisciplinary nature of the proposal, is important. So this should be, this should have a flavor of AI and technology and device technology, but also should have the clinical flavor and should be translational to aging and AD care. So we are looking for highly interdisciplinary types of projects. The track record of the PIs involved, the prior work, and how far along you are. Very early stage technology are unlikely to be of interest to us. Things that have the potential, where you have kind of demonstrated the potential, but you want to take it to the next level, are of significant interest. The impact, of course, can it lead to IP? Can it be translated? Will this actually lead to something that's widely used? And as a secondary review criteria, we are looking for whether this will create data sets. I mean, AI relies on, in part, useful data sets. So we are looking for, would this pilot result in data sets, or software or hardware that would be very useful for the community at large. Since we are built as a research accelerator to allow pilot projects to work efficiently within a year, we are also looking for how you might leverage the resources that we bring together in order to make your pilot a success. So just to end, I think I mentioned this in the short clipping as well, but we encourage you to reach out to us, and we would love to hear from you. If you send us a few paragraphs on what you're thinking about, we'd be happy to respond. I think these pilots, oftentimes it requires that engagement with the center. So we would love for you to reach out to us. This is our email. And if you reach out to us, and if you say, well, whether it's for teaming purposes or just to test an idea, please do contact us. All right, so I will stop sharing at this point, and
maybe I'll just add, Deepak, a few brief things, and then we can begin to take the questions from the chat. Thank you for those of you that have offered questions already, and we'd be pleased to answer any or all of additional ones if people have them. So first of all, welcome everybody, and thank you very much for joining. As you can tell by Deepak's background as compared to mine, we're really trying to bring together tech-oriented folks with clinically oriented folks to come up with solutions. And so the constraints on what we're talking about, and this will begin to answer some of the questions, are really successful aging at home, but across the divide from healthcare to home and back. But we're sort of, other than being about healthy aging or ADRD, somewhat agnostic to the disease state. It just has to fill within the constraints of healthy, successful aging at home, using technology or AI-based applications on top of this.
Well, welcome. We're so excited to finally be here at this point in our journey of writing this grant. It was a huge grant. We had a huge collaboration across many, many schools at Penn to put this together, and we're so proud of it and so excited at the response to the request for proposals. So I'm here today to review with you some of the key points about what's unique about our Penn AI Tech Collaboratory. So I'm Kathy Bowles, and I'm the director of the Aging Focus Pilot Corps in collaboration with Dr. Pam Cacchione. We're both from the School of Nursing, and from the School of Medicine is Graciela Gonzalez Hernandez, who is the director of the ADRD Focus Pilot Corps. And at the top of this slide are our three principal investigators. So you just heard the voice of George Demiris in our overview video. And George is a Penn Integrates knowledge professor across the university between the schools of nursing and the School of Medicine, and an expert in home health care and the use of technology and monitoring devices in the home setting. And Jason is a geriatric physician with expertise in ADRD. And Jason Moore is the expert in computational biomedicine. And he was our former director of our Institute of Biomedical Informatics. And he's recently moved to Cedars-Sinai, as you see there. So we're really excited about this leadership team we have, a dream team from nursing, medicine, and informatics, as well as the 8 cores that George had mentioned that span across the university, the different schools, the different expertise that you all as applicants will have access to as you move through in those that are selected to develop their proposals and to carry them out. One of the unique things about our Penn program is that we have an ethics and policy core, which I don't believe any of the other AITCs have. So we're proud of that as well. So our overall purpose of this is we're going to fund studies, as you well know, in 2 areas, healthy aging and in ADRD patients. And we're going to solicit, select, and manage these pilot studies that we hope are going to develop or test technologies and artificial intelligence to do lots of things like predict needs and support decision-making and manage chronic illness for older adults and help them safely age in place. And the focus of our collaboratory is in the home setting. And you'll see later, we have some partnerships with home health agencies and other services that are providing care in the home to keep people aging in place that we can offer as partners and collaborators. We want to optimize care management and health outcomes for older Americans, including those with ADRD. We want to, again, keep them in their homes. And we want to foster collaborations with scientists across Penn, as well as to network you with collaborators across the nation and in industry and home and community-based services that can support your work and help spread it. So this slide will show you the details and key dates about the request for proposals. So we anticipate funding at least 10 pilots. Most of the projects are going to be funded for 12 months with a maximum budget of about $100,000 in direct costs. Up to $200,000 max in total, and a two-year projects will be considered. So if we fund you for a year and it's a great project, we're really happy with its progress and excited about its potential, you may apply for a second year. Applicants should focus on general older adult population and apply to the aging pilot category, or focus on ADRD patients and older adults and apply to that pilot category. And the due dates are listed here, and all of this information is on our website as well as on the general site for you to review again. So here's some example research objectives to give you an idea of what we're looking for. So we're looking for studies that are going to develop new or deploy existing telehealth technology in rural, underserved, or disabled populations to improve their chronic care management and or provide caregiver support. And we want to evaluate feasibility, acceptability, and impact of artificial intelligence and other technology applications that are going to predict physical, social, emotional needs of adults and their caregivers, again, to support them aging in place in their homes. We hope that some of these studies will develop innovative AI-driven devices for commercialization. So the NIA that funded this collaboratory is very interested in innovation and commercialization of products and the movement of those products along to the marketplace. We also hope to create and apply technologies that support formal and informal caregivers in providing care to older adults in their homes, and to conduct end-user evaluations of AI and other technologies to inform the redesign, implementation, and again, commercialization of those products. So the resources that are available to applicants that are unique to the Penn Collaboratory is Penn AI software. So this is an automated machine learning software where the investigator can put their data set into this software, and it will run various machine learning applications against that data set and help you choose the best method and the optimal model parameters for your data set. So it really takes a lot of the long grind work out of machine learning applications. Penn Signals also is one of our resources that is a software for helping to deploy machine learning models into clinical practice. And we have investigators and core leads and core members that are experienced in doing that. That would be a resource to you. The Penn Memory Center is an internationally known center that cares for Alzheimer's disease and related disorder patients, and the database of patients and access to expert clinicians there as well. The Institute for Biomedical Informatics, which all of us are members of, that are on all of these cores and as leads of this study as resources. A home care suite at the School of Nursing that would be available for simulation work, to install sensors and to do development work with patients or student nurses or other subjects that you wanted to bring in. And the New Cortland Center for Transitions in Health, which is located at the School of Nursing. That is a center that specializes on the care of older adults, has a T32 training grant within it, as well as many professors and trainees that have expertise in gerontology. And then the 8 support cores, which Dr. Demiris had reviewed in his overview, that again are available. So one of the other things we feel makes our Penn AI Tech Collaboratory unique is our collaborators. And we have many networks across the country of healthcare agencies, such as the Visiting Nurse Service of New York that provides home and community-based services, that have agreed to collaborate with us, that could give access to data or to patients who are living in their homes and receiving home care and services in their homes. The PACE program, there's one right in Philadelphia, used to be affiliated with School of Nursing and now still works closely with us, as well as a national network of PACE sites that are nursing home eligible older adults, trying to keep them safely in their homes, a great population for these proposals. The LHC Group, a huge home health agency that cares for patients across 35 states across the nation. And then Trinity Health, which is an integrated healthcare system that also provides care across the country, a Catholic health system. So give you a little bit about the evaluation criteria of how we're going to evaluate the applicants. Well, we're first going to look for a fit with our collaboratory themes of using technology and AI to optimize health and care management for older adults living in their homes. Very simple, very straight. The overall impact of it is going to be rated against the standard NIH evaluation criteria. So we're looking for proposals that are addressing a significant problem. We're looking for a team of investigators that we feel confident can pull off what it's going to take to complete the project. Is it innovative? We're very interested in moving the science forward and creating new innovations. Is the approach strong? Does what you propose to do make sense that you will be able to complete it? And the environment that you're working in, the resources that you have, the team you put together, the place you're at, the product that you have to move forward. And then the potential to lead to future funding. So we want to know, is this a pilot that's going to lead to an R01 or future NIH funding? Or does it have a future for commercialization or for further developing a pipeline of products? Is it proving effectiveness, or is it an implementation trial? We're trying to move a product into practice. And then is it feasible for completion within a 6 to 12 month time frame? And we're looking very interested to see, did you include team members from multiple disciplines? And do you have an appropriate budget and a timeline for getting the work done? And so we welcome you to visit our website early and often, read all about this. You're going to see this very similar information of what I just covered on these sites.